Hi there and welcome. My name is Dr. Marlena Jabara, and I'm the proud founder of RadPodSquad. The RadPodSquad Fellowship offers an immersive learning experience tailored specifically to podiatric imaging. RadPodSquad combines comprehensive curricula, cutting-edge techniques, and on-demand access to training that will provide you with the new knowledge and skills that you need to boost your confidence in imaging and truly make a difference in treating your patients. Check us out today, radpodsquad.com. When we're looking at pes cavo varus alignment assessment, it's essential to start with quality weight-bearing x-rays. There are multiple measurements that you can obtain to assess hindfoot alignment. One of them is a simple dorsal talar line, and you're taking a bisection of the talar neck midway between points on the neck and midway between points on the articular surface, drawing a line and seeing whether it goes through the first metatarsal axis. If it's lateral to the first metatarsal, that's considered varus, and if it's medial, it's considered valgus. When we can see in this patient who has that medial peritalar rotation relative to the navicula, and we drop that bisection, we can see that it's far lateral to the hallux. So that's the first thing, the dorsal talar line. Then we have Kite's angle. On the AP projection, this is one of the better ways to assess whether or not you have hindfoot varus. So we're going to create a wall, a lateral calcaneal sidewall. We'll create a line with the lateral calcaneal sidewall, and again, bisection of the talar neck, and we'll understand the angle that lives between them. In patients who have varus, the talus has rotated medially relative to the navicula, and that angle is getting smaller. Sometimes it can be hard to see the lateral calcaneal sidewall, and some people will have to use an increased KV to cause penetration of this area. So normal, they say between 15 and 30 degrees, and under 15 degrees to be a situation of hindfoot varus. One important angle they talk about, very important in flatfoot, the talonavicular coverage angle, but it's just as important in cavus. I use the talonavicular angle to understand where the sclerosis is occurring and, of course, where the vector lies. For patients in the neutral position, we'll be expecting to see that when we look at the articular surface as composed to the navicular articular surface, comparing the talar versus navicula, we can see that lines connect these surfaces normally about 7 degrees. And when we have medial peritalar rotation, it sets up an axis that it's actually a negative angle. So that medial navicular subluxation is seen in hindfoot varus. And when we have the opposite, where the talar head moves medial, that's called uncovering of the talar head, and that's seen in pes planus. We can see lines like the SEMA line. These are lines that denote Chopard's articulation. And in patients that have pes cavus, we can see superimposition and breakage of our SEMA lines. So the lines are disrupted due to the lengthening of the lateral column that's occurring here. And you can see that both in the AP and the lateral projections. Moving on, those dorsal talar lines, the most important to assess. This is the most clinically important, applicable for ease and reproducibility. So you want to get very comfortable in understanding how to bisect the talus using the midline of the neck and the articular surfaces to create a line that can be reliable. And of course, again, our example of hindfoot varus, as we bisect the talus and come to that midline, we see that we're lateral to the first ray. There are multiple measurements, again, in hindfoot alignment. The lateral first metatarsal angle, the most important, in my opinion. What you want to do is find the lateral talar process and the dome and bisect it, find the neck and the head, and find those points to create the line and the vector of the talus. And if it's normal, it will take it down the first metatarsal. In patients of pes cavus, we see elevation of that axis. And in pes cavus, one other feature that's not talked about is where is the apex of the deformity? So in apex of deformity in a high rear foot arch, we can see that there could be the deformity would be at the talonavicular joint. In other patients, it could be at the naviculo-cuneiform and the first metatarsal cuneiform base. So knowing where the apex of the deformity is very important for the clinician, because this lets us know on some level what soft tissue structures may be failing predictably, understanding where the apex of the deformity and where might be the restricted ranges of motion. Of course, the calcaneal pitch angle, 18 to 20 degrees, is considered normal, although there's a wide range, and it increases with pes cavus, especially rear foot cavus. In this case, again, we have our talus, the vector of the talus, and the apex of the deformity here is at the Lisfranc articulation. Looking at the lateral talocalcaneal angle, in a situation where we have the normal talus and we can see the bisection of the line against the line at the plantar calcaneus to the base of the anterior calcaneus, the anterior calcaneal process, and we can see the lateral talocalcaneal angle formed by these axes, normally 25 to 45, and a decreased angle is going to indicate pes cavus. So the talus is becoming more vertical and coming down closer to the ground, decreasing this angle. Looking at, again, that SEMA line, a normal SEMA line dividing Chopard's articulation can be broken. So here I can have a continuous S-shaped line. And in this case, with a broken SEMA line, this indicates the disruption, indicates that there's relative lengthening and changes of the columns and may indicate abnormal biomechanics. The see-through sign and the lack of superimposition of the domes is a common finding. And notice the posterior fibular positioning that can occur. Pes cavo-varus alignment assessment, the lateral first metatarsal line, again, this line that bisects the talus from the dome to the lateral process from the neck and the head. This angle formed by the talar and the first metatarsal axes is the most clinically applicable for ease of assessment and reproducibility. Normal would be 0 degrees. It can be less than 4. Greater than 4 degrees, convex upward, indicates pes cavus. In this case, there's clearly more than 4 degrees. We can see that the vector of the talus and the first metatarsal angle have the apex of the deformity angled superiorly. Are you ready to take your podiatric imaging skills to new heights? Check us out at RadPodSquad.com. Explore our online learning community. And don't forget to like and subscribe to our YouTube channel for more enriching content.